Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's program is OPZELURA in Practice, Vitiligo Real-World Case Studies. As moderator this evening, we have Dr. Firas Hougier, Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialists. As speaker this evening, we have Dr. Heather Woolery-Lloyd. She is Director of the Skin of Color Division, Dr. Phillip Frost, Department of Dermatology and Cutaneous Surgery, the University of Miami, Miller School of Medicine. We would like to thank our supporter this evening, Incyte Dermatology, for making this educational event possible. A couple of logistic tips before we begin. If you're having any issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this very short survey. And again, as a reminder, at the end, we will have a Q&A, so please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Hougier.
Good evening. Thank you so much for joining us for another IDEF educational seminar. It is my distinct pleasure to introduce Dr. Woolery-Lloyd today. Before so, please know that this is brought to you by the IDEF. The IDEF is a nonprofit organization whose principal mission is to give awareness, education and raise the awareness of dermatology care all over the world through this education, especially in underserved areas. Dr. Leon Kircik is the president and founder of this organization that has been now functional for several years. We have had multiple educational sessions in the past, some of which you can see here with illustrious speakers like Dr. Craig Lowe, Dr. DeRosso, and others. It is our pleasure to have you here today. And please, if you have the desire to stay up to date with the IDEF educational series, you can join the Instagram as well as LinkedIn or Facebook pages of the IDEF Foundation. And today we have Dr. Heather Woolery-Lloyd, who is going to speak to us about vitiligo treatment and OPZELURA. Dr. Woolery-Lloyd is, again, the Director of Skin of Color Division at the University of Miami Miller School of Medicine. She is an illustrious speaker who I've had personally the pleasure of hearing at many meetings, including nationally and internationally. She does lecture nationally and internationally and is an investigator in dozens of clinical trials with a focus on increasing the inclusion of skin of color patients in these trials, which we all know we need tremendously. Dr. Woolery-Lloyd, the floor is yours.
Thank you so much. Well, I'm really excited to be here today to talk about OPZELURA, and this is a new talk because I'll be talking about some world case studies, so real life case studies. And I will be, let me just get my mouse going, there we go. So we're going to be talking about OPZELURA in practice, and these are real world studies really showing what it's like. This has been out for a few years now. Really, this talk will show you what we can expect in the real world in clinical practice. So let's jump right in. So of course, this is a promotional presentation that's being sponsored by Incyte, and I'm speaking on behalf of Incyte. The information I'll be presenting will be consistent with the US FDA regulations. I'll be able to answer questions that are on label. And of course, I'll be discussing some important safety information throughout this talk. And there is full prescribing information available to you for OPZELURA during this presentation. So what is OPZELURA indicated for? Well, we know it's indicated for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. It has a second indication, and that second indication is the topical, short-term, and non-continuous chronic treatment of mild to moderate atopic dermatitis in non-immunocompromised adult and pediatric patients 12 years of age and older who aren't responding to therapy. Of course, tonight we're going to be talking about vitiligo, but it does have those two indications. There is a limitations of use statement, which is that use of OPZELURA in combination with therapeutic biologics, other JAK inhibitors, or potent immunosuppressants such as azathioprine and cyclosporin is not recommended. So I'm going to start this talk with some important safety information and end this talk with some important safety information. And OPZELURA is a JAK inhibitor. We're going to learn a little bit more about OPZELURA tonight. And this is a class of drugs that has been in the rheumatology world for longer than it has been in the dermatology world. So there is some important safety information that's been gathered over the years from the previous use of JAK inhibitors in rheumatology. So the things that the important safety information I want to go over today are the risk of serious infection leading to hospitalization or death, including TB, bacterial, fungal, viral, and opportunistic infections. These have been observed in patients who have received JAK inhibitors for inflammatory conditions. Also, higher rate of all-cause mortality, including sudden cardiovascular death, has been observed in patients who have used JAK inhibitors for inflammatory conditions. Lymphoma and other malignancies have also been observed, and higher rate of MACE, which are major adverse cardiac events, have been observed in patients who have been treated with JAK inhibitors for inflammatory conditions. Finally, thrombosis, including deep venous thrombosis, pulmonary embolism, and arterial thrombosis, have occurred in patients being treated with JAK inhibitors for inflammatory conditions. But we're going to talk about the details of the important safety information again at the end of this talk. So let's first start with a vitiligo overview. So when we think of vitiligo, there's two types of vitiligo. There's segmental vitiligo and there's non-segmental vitiligo. Now, segmental vitiligo is usually located on one distinct area. It does not cross the midline. Usually there's early hair follicle involvement, and it can progress very rapidly, and then it stabilizes. So OPZELURA is not approved for the treatment of segmental vitiligo, but the vast majority of the vitiligo we see in practice is non-segmental vitiligo. And there are four different types. So there's the generalized type, there's the acrofacial, where it's basically the face and the hands or extremities are involved. There's universal vitiligo, where the majority of the body is involved, or focal vitiligo. So it's important to keep in mind that OPZELURA is approved for non-segmental vitiligo, but the vast majority of patients who present to our practice have non-segmental vitiligo. Non-segmental vitiligo tends to progress very slowly, but what's very interesting about it is that it does have an unpredictable course. And this is one of the most challenging things I see in my practice, because a newly diagnosed vitiligo patient will often ask, is this going to progress? That's the number one question I will get when someone walks into the practice newly diagnosed with vitiligo. And the answer to that question is, I don't know. It really can have this very unpredictable course. Now, we do know with an earlier age of onset, usually that can sometimes suggest that it might be a little bit more aggressive disease, but not necessarily. But it's one of the most challenging things I think I have with my newly diagnosed vitiligo patients, is that we really can't predict. It can be quite unpredictable, the course of vitiligo with non-segmental vitiligo. So our treatment goals when we see a patient with vitiligo, there are mainly three things that we think about. First, and most important, we want to stop that autoimmune response. We want to reduce inflammation and stop further destruction of the melanocytes. Second, we want to repigment the skin, and it takes time for those melanocytes to repopulate. So that's important. We're going to talk about how much time it can take a little bit more in this talk. And finally, we want to maintain repigmentation. So just as much as pigmentation is important, maintaining that pigment is equally important. And patients are very concerned, because sometimes in the past, patients with vitiligo might repigment and then lose their pigment again. And it's really important to maintain that pigment. And we can do that by reducing activation of those resident memory T cells in the skin. So when we talk about repigmentation, it's important to note that different areas of the body repigment at different rates. So the fastest areas of repigmentation are seen on this slide in blue, and they have the highest density of hair follicles. So the face, the arms, the legs, the abdomen, and the back, those are the areas that are most likely to repigment quickly. And I practice in a very sunny climate. I'm down in Miami, and I can say with confidence to my patients that we can repigment your face. Why? Our face is full of hair follicles, and I have a lot of sun that kind of helps me along. The areas that are a little more slowly to repigment are areas that have lower density of hair follicles. So that would be the dorsal hands, the dorsal feet. Those areas that you can see in this diagram in gray are going to repigment, but definitely much more slowly. And then, of course, there are areas that may not repigment at all. And it's important for us to point this out to our patients, because those areas are areas where their hair follicles are either absent or they're very low in density. So we're talking about the palms and the soles. We're talking about the volar wrist, this area where we don't have a lot of hairs. Those are definitely the most challenging to repigment, and they may not repigment at all. And a little clinical clue is if there's no pigmented hair or there's leukotrichia, so white hair in the affected area, it is less likely to repigment. So that's another clinical clue that you can look at and point it out to your patient. It's okay to say that those areas might not repigment, because we do know with confidence that areas that are full of follicles should repigment and repigment quickly. So repigmentation definitely takes time. It takes months. This is not something that, in a week or two, you're significantly better. Because, as I mentioned, you have to stop that autoimmune response, stop the destruction of the melanocytes. And then, as you can see here in this beautiful diagram, these melanoblasts have to travel up the hair follicle to repopulate the epidermis and to restart making pigment. And when we see that, we see these islands of repigmentation, these beautiful islands of repigmentation. We call that perifollicular repigmentation. That's the most common way and the most common pattern of repigmentation. But patients with vitiligo can also have marginal repigmentation, which we can see right here. And that's when the melanocytes travel from the normal appearing skin outside of the lesion in. And we're going to see some beautiful images today of marginal repigmentation, so you can know exactly what to look out for. This takes much longer. So perifollicular repigmentation is quicker. Marginal repigmentation definitely takes longer, but it is another way for our patients to repigment. So let's talk about OPZELURA and the treatment of vitiligo. And we'll start with the clinical trials that led to the approval of OPZELURA, which were TRuE-V1 and TRuE-V2. And these were identically designed phase 3 double-blind vehicle-controlled trials. So to get into this trial, the patients had to be adolescents or adults at least 12 years of age or older. They had to have non-segmental vitiligo, as I mentioned. They had to have vitiligo areas affecting at least 0.5% of their facial body surface area and at least 3% of their non-facial body surface area. And then the total body vitiligo could not exceed 10% BSA. And in this study, 1% BSA was a full hand, so the palms and your fingers. So they couldn't have more than 10 hands worth of vitiligo or 10% BSA. They were not allowed to do phototherapy in the trial, and patients with complete leukotrichia within any facial lesion were excluded. Why? Because of what I just mentioned. If you have leukotrichia, it's much harder to repigment because the melanoblasts are in those hair follicles. So in the study, they were randomized 2-to-1 to receive OPZELURA or the vehicle, and the primary endpoint was at week 24. And the main primary endpoint was the proportion of patients who achieved a 75% improvement in their facial vitiligo. That's also called an FAAD 75. So that was the primary endpoint for the trial that led to the approval of the drug. However, there was a long-term extension, and at week 24, the people in the vehicle group were switched over to the active OPZELURA group, and they used the treatment twice daily, monotherapy twice daily, and then this trial ended at week 52 with a 30-day follow-up. So there were some other key secondary endpoints. So they wanted to look at week 24. the FAAD 90 or a 90% improvement in facial vitiligo, the FAAD 50, which is a 50% improvement in facial vitiligo, and a TVASI 50, which is a 50% improvement in total body vitiligo at week 24. And then they also had some select endpoints at week 52, which were an FAAD 75 at week 52 and a TVASI 75 at week 52. So when we look at the demographics of these patients, they were on average around the late 30s, 39 to 40 years old, slightly more women than men, but there was a large skin of color population. Around 20% of the patients in TruV1 were skin of color, 30% of the patients in TruV2. Now you see those big circles on the right. These are really important demographic pieces of information that gives us a feel for the patients that were in this trial. And I think one of the most important ones is that big orange one, which said that the average duration of disease since the initial diagnosis was 14.8 years. So these patients had had vitiligo on average for almost 15 years. And the reason why this is so significant is because a lot of times patients with vitiligo think that if they've had disease for a decade or more, there's no more treatment options. So it's important to note that in this trial, many of the patients had had vitiligo for over a decade, on average 14.8 years. So I don't want people to feel discouraged that if someone has had vitiligo for decades that they're not likely to respond, because the data from this trial suggests that that is not the case. The other thing of note is that the average total body surface area was 7.4%, so around 7.5 hands, around 7.5 hands. And then for the face, the average affected facial body surface area was 1%. So this was the primary endpoint of the trial, which is an FAAD 75 at week 24. And around 1 in 3 patients met that primary endpoint. It was 29.9% of subjects in both trials, TruV1 and TruV2. This is a really well-designed trial because both TruV1 and TruV2 had the exact percentage, 29.9% of patients, or almost 30% of patients. So the important thing when I look at this chart, I want you to pay attention to week 8 here. And the reason why this is important is because I want us to remember that, this talk is about real world use of OPZELURA. We don't want to bring our patients back too quickly, because you can see here that the active group had basically similar results to the vehicle group through week 8. But then finally, once that inflammation was suppressed and those melanocytes or melanoblasts were able to repopulate the epidermis, you see that breakaway at week 8. So one of the take-home messages, just by looking at this graph, we can see that you don't want to bring your patients back too quickly. Don't bring them back at 2 months because you're not likely to see a response. You can see that breakaway at week 8, and I actually bring patients back at 4 months, around 3 to 4 months, because I really want some time for those melanoblasts to repopulate the skin for a follow-up visit. Now, let's see, this trial went out to week 52, and you can see at the end of that week 52, remember this gray line here, these were the vehicle patients. From week 24 on, they were transferred into the active group. So from this point on, everyone is on drug. And you can see the people who were on the entire time, 51% of them, or around 1 in 2, achieved an FAAD 75 at 52 weeks. And not surprisingly, once that vehicle group got to use the OPZELURA, around 28% of them achieved that FAAD 75 at 52 weeks. So they had gotten 24 weeks of therapy. So it mimics almost exactly to what we saw in the first 24 weeks of the trial for the people who were on the active. So really nice, beautiful results in this trial with the primary endpoints at that secondary endpoint. But just as important as efficacy is tolerability. I think tolerability is just as important as efficacy. So let's look at the treatment emergent AEs at 24 weeks. So we can see here that the most common treatment emergent AEs were application site acne and application site pruritus at 6 and 5% in the OPZELURA group. And then this was followed by nasopharyngitis and headache, which were at a rate of around 4% in the OPZELURA group, followed by urinary tract infection and application site erythema at 2% and pyrexia at 1%. It's also important to look at what percentage of patients discontinued due to the treatment emergent AEs? And discontinuation due to treatment emergent AEs was very low in this trial. So you can see that 0.5% and 0.9% discontinued due to treatment emergent AEs for OPZELURA and vehicle. So you can see 0.5% for the OPZELURA discontinued and 0.9% for the vehicle in TRuE-V1, and 0.4% and 0% discontinued for OPZELURA and vehicle in TRuE-V2. So very few patients discontinued due to these treatment emergent AEs. And then when we look at adverse reactions that occurred at a rate of greater than 0.5%, but less than 1%, and were observed in the OPZELURA group, but not in the vehicle group, were the following. So we saw application site dermatitis, hypertension, anxiety, application site discoloration and folliculitis, contusion, dermatitis, diarrhea, ear infection, gastritis, gastroenteritis, hordeolum, influenza-like illness, insomnia, nasal congestion, and vomiting. So these were the things that were less than 1%, but occurred more frequently in the OPZELURA group. Now, at the treatment emergent AEs at week 52 were very similar to those seen at week 24, and there were no additional safety signals observed through week 52. So, you know, we can see COVID-19, this was during the pandemic, but we see the same things, the application site acne and pruritus at 6 and 5%, nasopharyngitis, headache, upper respiratory infection, and sinusitis. So these were similar, and there were no additional safety signals. And then, of course, the most common treatment emergent adverse events were, treatment-related adverse events, and those were the ones that were decided by the investigators were thought to be related to the topical treatment, were application site acne and pruritus, which we know are very common with JAK inhibitors, particularly acne. That's a very common side effect. So no serious treatment emergent AEs were considered by the investigator to be related to the treatment, and it looked like the tolerability was similar at week 52 compared to week 24. Now you hear us talking about the important safety information a lot when we talk about OPZELURA, and I wanted to give you some framework as to where this data comes from. So there was a post-marketing study for an oral JAK inhibitor. It was on Xeljanz, which is tofacitinib. And in this study, they had patients who had rheumatoid arthritis, who were 50 years of age and older, who had at least one cardiovascular risk factor, and they were on methotrexate. And half of those people were treated with this oral JAK inhibitor, Xeljanz. The other half was treated with the TNF-alpha inhibitor. So in this study, the patients who were treated with methotrexate and the oral JAK were more likely to have an increased risk of increased risk of death, malignancy, MACE events, and VTEs, or venothrombotic events. So that is where this comes from. This is called the oral trial, or the oral rheumatoid arthritis trial. So based on this data, the FDA concluded that some JAK inhibitors indicated for the treatment of inflammatory conditions may have similar risks. And the US prescribing information for these JAK inhibitors includes a corresponding boxed warning for these hazards. And you should take this into account when considering treating patients with OPZELURA. Now, this is something new that you may not have seen before. I don't think you've seen this before. And this is a patient survey that was done this year. Remember, the focus of this talk is to really focus on real world data. So this was an online survey for patients that were treated in this year, and it was done between March and May of 2024. There were 105 subjects with non-segmental vitiligo who had been using OPZELURA for at least 3 months, and they were asked about their treatment experiences. So in this real world survey, 90% of patients who used OPZELURA for repigmentation agreed that it was worth their time and effort to use this. And 98% agreed that OPZELURA was easy to use for treating their non-segmental vitiligo. And more than 8 in 10 were extremely likely or very likely to recommend OPZELURA to a family member or friend with non-segmental vitiligo. So I love this study because it's real world data, and it's nice to know that 90% of patients felt it was worth their effort. 98% felt it was easy to use, and at least 80% felt that they would recommend OPZELURA to a friend or family member with non-segmental vitiligo. So this is really good feedback to have, real life data to hear back from our patients. So how is it dosed? OPZELURA obviously is a non-steroidal cream, so it's safe for sensitive skin areas. This is particularly important in vitiligo because we tend to see vitiligo around the eyes, around the mouth, in the underarms, in the groin. So it's very, very helpful for it to be non-steroidal because it can be used on all of these sensitive areas. Of course, it's for topical use only, not for ophthalmic, oral, or intravaginal use, but definitely for patients with vitiligo in their underarms or the groin or on their face, we can definitely use this safely because there's no steroids. The directions are to apply a thin layer twice daily to the affected area, up to 10% BSA, because remember in the clinical trial, up to 10% BSA was treated. Patients should not use more than a 60-gram tube in a week. And I've never had a patient have this issue, but it's something that is on the label and something for us to keep in mind. Now we're going to jump into some of the real world cases. These are cases that are in our communities submitted by clinicians who are treating patients with vitiligo. So the first case is a 62-year-old man with vitiligo on the face. And this case details and photographs are provided by Andrew Alexis. Dr. Andrew Alexis. So this is a man, he had vitiligo for 8 years, skin type 4. He was diagnosed at 54 years old. He has a family history of vitiligo in his mother and sister, which is very common. I often ask my vitiligo patients if they have a family history of autoimmune illness. And I'll ask about things like psoriasis, alopecia areata, lupus. But I even ask about early graying because some people think that poliosis or early graying may have an autoimmune etiology. So I think it's helpful because it gives me kind of a big picture of that patient. And it's not surprising to me in this patient that he has a family history of vitiligo. I do often see a family history of autoimmune disease in general in my patients. There was prior treatments for this patient. So he had used topical corticosteroids for 2 years with no repigmentation. He'd also used a topical calcineurin inhibitor with no effect on his depigmentation. And this is what he looked on physical exam. You can see the vitiligo affecting his face. And he was started on OPZELURA 1.5% cream twice daily. And let's look at his results. So this was what he was like at baseline. And at week 24, you can see beautiful repigmentation of that cheek with just a few little hypopigmented areas remaining. So this is what I would call a perfect response, right? At week 24, he really filled in beautifully. He did not report any issues related to tolerability, and the OPZELURA treatment was ongoing as of that last visit at week 39. So a pro tip to take home for this patient is that follow-up is key. Monitor patients for adherence and repigmentation regularly. So I don't know if he came back anytime between baseline and week 24, but I would definitely say wait at least 3 to 4 months for a follow-up visit, only because you want to make sure that they have some repigmentation. I wouldn't bring the patient back in 2 months. He had beautiful repigmentation at week 24. Now we have the next patient, which is a 34-year-old woman with vitiligo on her thighs. So this patient was provided by Dr. Amy Spizzuko, and she presented for a skin check, but on her skin check, she noted patches of depigmentation symmetric on the left and right thighs. So she had no prior treatment for her vitiligo. She had no comorbidities. She reported that these had been present for 1 year. So this was basically an incidental finding on a skin check. And you can see here these very symmetric, well-demarcated, depigmented patches on the bilateral thighs. And she was started on OPZELURA 1.5% cream twice daily. So let's see how she did. So it's important to note at week 6, there was no improvement in the non-segmental vitiligo, but the treatment was continued. We wouldn't expect improvement at week 6, as I mentioned, because it really takes some time after you stop the inflammation for the melanocytes to repigment that epidermis. But you can see here now at week 30, week 43, and week 62, she's really starting to fill in. So what we can see with this case is a beautiful case of marginal repigmentation. And that's when you see the repigmentation at the borders. And one of the clinical pearls is that you can see at baseline, her vitiligo is very well demarcated, almost like a perfect stamp of depigmentation on her skin. But as she progresses from week 30 to week 43 to week 62, you see that sharply depigmented line is less obvious, and you see this marginal repigmentation where the borders of the lesions become a little bit more blurred. She also has some islands of repigmentation within the lesion, but this is a nice case to show how that marginal repigmentation looks. So you're changing from this look of a sharply demarcated patch that's very, very well demarcated to this very amorphous border, and that's a sign that there's some marginal repigmentation. So the provider noted that the patient was satisfied with the progress to date. She continued treatment, and given the treatment progress and patient tolerability, OPZELURA was continued, and it was ongoing as of the last visit, which was week 62. So this is something for you to think about when you're seeing your patients. If you see these blurring of the borders, it's starting to fill in, but there's not those clear islands of repigmentation. Think about marginal repigmentation. Point that out to the patient, and you can even show pictures. We're going to show a great case, another great case of marginal repigmentation soon. Now, patient 3 is a 53-year-old female who has vitiligo on the neck. So she's had vitiligo for only 2 months, so pretty much a new diagnosis. And she has these patches of depigmentation on the neck and the fingertips of both hands in recent months. She was diagnosed with non-segmental vitiligo. The prior treatments were none. She had no comorbidities because this is a new diagnosis. And basically on physical exam, depigmented lesions were noted on the neck and the fingertips, but there were no baseline photos for this patient. So OPZELURA was initiated 1.5% cream twice daily. So you can see here, this patient, again, has no baseline photos, as you can see right here, but at week 18, you can see these beautiful islands of repigmentation on the neck. And this is just a beautiful case of these islands of repigmentation. At week 47, you can see those islands are getting larger, and at week 56, even larger. So you can see that she is repigmenting both marginally, but primarily with these islands of repigmentation. And I can imagine her baseline photo, probably all of these areas were empty. So she had a beautiful response. You can see that response, and it's very clear that she's improving with this topical treatment. The provider reported that the patient was satisfied with the progress to date and wished to continue treatment. And it was helpful for her to see these side-by-side photos. She was so pleased with the side-by-side photos that she took pictures of the images from the provider and used them to track her progress at home. And she continued to use the OPZELURA as of her last visit. So the clinical pearl here is to take baseline photos. I think they're particularly helpful for vitiligo because sometimes the response can be subtle. So we want to look for maybe blurring of the margins with marginal repigmentation or new islands of repigmentation. So emphasize to our patients that repigmentation takes time, ongoing adherence is important, and take photos if you can, because I think it's very helpful for us to track, but also for the patient to see that there is improvement with the topical therapy. Now, patient 4 is a 32-year-old male with vitiligo on the face. He's had vitiligo for 1 year, skin type 5. This case was, and details, the photographs are provided by Andrea Nguyen. And the patient had no family history. Important to ask about that, I always ask. And his prior treatments included topical steroids and topical calcineurin inhibitors. On his face, this is what we see. We see vitiligo primarily on the side of the face, the side of his nose. We see a patch on his forehead. And let's take a look at how he did. He was started on OPZELURA and twice daily, And this is what he looked like at week 6. So you see some islands. So I would say he's a pretty fast responder based on my practice, because you do see some islands there even as early as week 6. You can see in this area, it's getting a little bit more prominent. These patches are a little bit darker than they were over here. And then you can see at week 12, 20, and 28, he continues to fill in, and he does beautifully. At week 28, he's beautifully filling in. His vitiligo is doing well. So the patient tolerated the treatment well through week 28, and he was encouraged to continue the twice daily treatment with OPZELURA. But having these pictures were really critical, because you can see this beautiful progression over time of how he did. Even though he was brought back at week 6, you might not expect to see a response. He was, I would say, a fast responder. So you can think about this patient in comparison to some of your patients. It's important to know with OPZELURA, we have patients who respond quickly, we have patients who respond slowly. In this case, I think this patient really was a fast responder, especially when you look at that week 6 visit. But don't get discouraged if you have a slow responder, because based on the studies, even the slow responders do respond over time. And our last patient is a 12-year-old girl with vitiligo on her knees. And you can see here she's had vitiligo for 2 years. She's Fitzpatrick skin type 2. And this case was provided by Dr. Eric Dominguez. So the patient had spreading depigmentation, non-segmental vitiligo on the legs and feet, and had no benefits from their current treatment. This patient was actually waiting to turn 12 years old so she could start OPZELURA. Her previous treatments included clobetasol for 16 months, a topical calcineurin inhibitor for 16 months, and she interestingly had the comorbidity of Hashimoto's thyroiditis. I think this is a great teaching case, because in children in particular, I think in all ages, but in children in particular, there is an association with vitiligo and autoimmune thyroid disease. So I think it can be helpful to check the thyroid, and not only the thyroid, but thyroid autoantibodies in newly diagnosed children with vitiligo. We can also do this in adults, but I think this becomes really significant in children. So you can see her knees at baseline. You can see these sharply depigmented patches on both knees. Of course, she was started on OPZELURA, and let's see how she did. So you can see her here at week 0, and then at week 57 and at week 77. And this is another case of marginal repigmentation. So one thing of note was that week 12, there was no improvement at all. And the patient was encouraged to use the treatment twice daily, because they had reported some inconsistency or poor adherence, non-adherence to that twice daily use. So the patient and her mother were counseled on the importance of adherence. And then at week 57 and week 77, we see some repigmentation. Once again, I want to point out that the sharply depigmented patches are now, those borders are now ill-defined, and that's a sign of that marginal repigmentation. And she also has some new islands of repigmentation that you can see here highlighted with the red arrows and the circles. So she was very excited to see some of her results at week 57 and week 77. And so the OPZELURA treatment was ongoing as of the last visit, which was at week 77. So what's a pro tip for this case? Adherence is key. Remind patients to apply OPZELURA twice daily every day. So let's get some takeaways from these cases. So we want to counsel our patients during the OPZELURA treatment. This is really important, and it's really important to set realistic expectations for our patients. So what do our patients need to know? They need to know that repigmentation takes time. In the cases, we saw some fast responders and we saw some slower responders. And the fast responders, if you remember, were primarily on the face. They were the 2 men with vitiligo on the face. So I do tell my patients, with confidence, your face will repigment most quickly and will get really great results on your face. I also have a little bit of extra help practicing in sunny Miami. We have a lot of sun here, so that I think pushes it along a little bit faster than if I was in a colder climate. But definitely explain to patients that repigmentation takes time. The face is the fastest to respond, but other areas like the, certain parts of the extremities may take longer. Adherence is key. Twice daily, every day. We saw that case of that young 12-year-old, I was going to say a teenager, but she's a tween, who was non-compliant in the beginning, but once she became more compliant, she saw some response. Of course, some parts of the body repigment faster than others, and some may not repigment at all. So as I mentioned, the palms, the volar wrist, other areas, the mucosal areas that don't have hair follicles, or if there's complete leukotrichia, those areas are not likely to repigment. And it's okay to tell your patients that. And of course, follow-up is key. We want to follow up anywhere between 3 to 4 months. If you bring them in sooner, that's fine, but don't be surprised if you don't see repigmentation. You may see it on the face, but you're less likely to see that on other parts of the body. Remember that OPZELURA is a non-steroidal cream. It can be used on sensitive skin areas, obviously the face, around the eyes, the underarms, the groin, up to 10% body surface area, and it's available in a 60-gram tube. So OPZELURA, I haven't mentioned this before, but it's actually the first and only FDA-approved topical JAK inhibitor, and it's for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. So of course, we want to set realistic expectations. We've really driven that concept home because the patients need to be really patient. Now, in my practice, patients are always encouraged, even if they see one island of repigmentation, they're very, very optimistic. But you might not have patients like that, and you might have patients who may feel discouraged. So it's really important for us to be the cheerleader and to let them know that it does take time to repigment, and they have to be compliant and continue to use it twice daily to continue to see that repigmentation. Now, in the clinical studies, 1 in 3 patients achieves an FAAD 75 at week 24, and in the long-term extension, 1 in 2 patients achieve that FAAD 75 at week 52. So this is a non-steroidal cream, as I mentioned. It's safe for all external areas, so we can use it around the eyes. We see so much vitiligo around the eyes and around the mouth in the external genitals. And the most common adverse reactions, as mentioned earlier, are application site acne and application site pruritus at 6 and 5%, headache and nasopharyngitis at 4%, UTI and application site erythema at 2%, and pyrexia at 1%. Now, I told you we were going to start with important safety information and we're going to end with important safety information. Let's go over that safety information. Now you know the background of the oral trial, which is the trial that looked at an oral JAK inhibitor in patients who were 50 years in age and older who had 1 cardiovascular risk factor and were on methotrexate. And in that trial, those patients were more likely to have serious infections if they were on a JAK inhibitor, the oral JAK inhibitor, compared to the TNF-alpha inhibitor. So serious infections are something that we want to look out for in our patients, and also avoid using OPZELURA if our patient has a serious infection. So things like TB, invasive fungal, bacterial, viral infections, opportunistic infections are something that were observed more in patients treated with an oral JAK inhibitor compared to the TNF-alpha inhibitor in that trial that I mentioned earlier. So you would avoid using OPZELURA in patients with active serious infection, including localized infections. And if a serious infection develops, you definitely want to interrupt use and just closely monitor patients for signs of infection while they're being treated. There were no active TB cases reported in the clinical trials for OPZELURA. There was viral reactivation reported in the clinical trials for OPZELURA, and if a patient were to develop zoster, you would discontinue treatment. And of course, OPZELURA initiation is not recommended in patients with active hepatitis B or hepatitis C. And in that same trial, the oral trial with the oral JAK inhibitor, in those patients with rheumatoid arthritis who are 50 years of age and older with 1 risk factor, who were more likely, they were more likely to have all-cause mortality if they had the oral JAK inhibitor compared to the TNF-alpha blocker. So it's something for us to consider and weigh the risks and benefits if you're considering a patient with severe cardiovascular disease. It's important to note, though, that current or past smokers are at additional risk. So you might want to ask about smoking history in patients when you're considering Opzelura. Similarly with malignancies were reported in patients treated with Opzelura. Lymphoma and other malignancies were observed in patients treated with JAK inhibitors for inflammatory conditions. And in that same trial, the rheumatoid arthritis patients, there were higher rates of malignancies observed. So patients, again, who are current or past smokers are at additional risk, so it's something for you to consider. And if a person was to develop a malignancy, you would discontinue use. And of course, non-melanoma skin cancers were observed in the clinical trials. We often see that, so of course, continue to do your periodic skin exams for patients on Opzelura. In that same oral trial, which was the oral JAK inhibitor in the 50-year-old patients with one cardiovascular risk factor, they were also on methotrexate, there were higher rates of major adverse cardiac events or MACE events. And there were also higher rates of thrombosis. So you might want to weigh the risks and benefits if your patient has cardiac disease. Again, this risk is higher in patients who are current or past smokers. So you might want to, discuss this with your patient and discontinue Opzelura in patients who have considered an MI or stroke. And the same is true for thromboembolic events like pulmonary embolism, deep venous thrombosis, arterial thrombosis. This again was higher in the patients who had the JAK inhibitor compared to the TNF alpha blocker in that trial with the patients with rheumatoid arthritis. So if patients have a history of thrombosis, you might want to consider that if you're considering Opzelura in that patient. And of course, they were to develop thrombosis, we would discontinue and treat appropriately. And finally, I'm going to talk about some lab findings, which is another part of our important safety information. So thrombocytopenia, anemia, and neutropenia were reported in the clinical trials with Opzelura. So you would consider the risks and benefits if a patient has a history of anemia or thrombocytopenia. Lipid elevations have been seen with oral ruxolitinib. And then, of course, the most common adverse reactions were nasopharyngitis. Well, for the atopic dermatitis trial, they were slightly different. So nasopharyngitis, diarrhea, and bronchitis, eosinophil count increase, urticaria, folliculitis, and tonsillitis, and rhinorrhea. But for the non-segmental vitiligo, they were application site acne and application site pruritus, which we do expect with topical JAK inhibitors or with JAK inhibitors in general. Acne is common, folliculitis is common. Nasopharyngitis and headache were reported, UTI, application site erythema, and pyrexia. Now, there is a pregnancy registry, and there's a phone number that you see on the slide that you can call if a pregnant patient is exposed to Opzelura. And there's also a website, which is opzelura.pregnancy.incyte.com. And of course, we don't use Opzelura in patients who are breastfeeding or for approximately 4 weeks after the last dose, which is 5 to 6 elimination half-lives. So that finishes my talk, and we have time for questions. So hopefully you learned a lot. I loved presenting on these real world cases because it really gives us a very practical view of how our patients can respond in our clinical practice.
Thank you, Dr. Woolery-Lloyd. Great presentation. It was wonderful to listen to it. A couple of questions came into the system. The first one is, have you known of, is there any reported photosensitivity with this topical?
I, in my clinical practice, have not seen photosensitivity, and I'm in a very sunny climate, so I would expect, if that were to happen, I would have seen that. So in my practice, I have not seen that.
Wonderful. Next question, when do you consider discontinuing Opzelura? When or how long do you keep your patients on it before thinking, well, they haven't done what they needed to do?
So this is such a great question because, as I mentioned, there's fast responders and slow responders. And now we have data out for 2 years. And in a different slide deck, we see pictures of patients who at week 52 had minimal to, very little response, a few islands of repigmentation. But because it was a 2-year trial, they were continued on the topical out for 2 years. And then some of these patients completely repigmented. So the big take-home message is don't give up too early. Even if at week 52 you see minimal repigmentation, if you see any islands, I would continue, because I do feel that patients may be slow responders and you might discontinue a patient who would have fully responded if they had continued on an additional year. So we have 2-year data, and I would say at least 2 years.
Wonderful. And if they fully repigmented, then when do you discontinue, or do you discontinue?
Well, I think that, when we really understand this mechanism, you have to continue to suppress those T cells that want to destroy the melanocytes. So on-label use would be to continue it twice daily. Patients, when they respond, they don't want to discontinue because they are really excited to have their vitiligo treated and have a great response. So, in my practice, we continue. Really changing the dosing regimen would really be an off-label type question, but I do think that they need to continue to be exposed to stop those T cells from reactivating, those memory T cells, and going after their melanocytes again.
Okay. And last question, I think, before we wrap it up, why would you not use OPZELURA in segmental vitiligo?
Well, because the course of segmental vitiligo is different. It rapidly depigments and then it's stable. It also tends to have leukotrichia. So there's typically some of the segmental vitiligo has no pigmented hair in the lesion. It's highly unlikely if there's leukotrichia for that area to repigment because there is no reservoir of melanoblasts to come up and repigment the skin. So basically based on 2 things, basically that the clinical course is that it's a rapidly progressive but then stable disease. It doesn't tend to progress. And the second reason why is because it tends to have leukotrichia, so it's not likely to respond.
Wonderful. Dr. Woolery-Lloyd, thank you so much for your great presentation. Thank you, everybody, for your attendance. And thank you to our supporter, Incyte Dermatology, for making this session possible. Have a great night, everybody.